So let's ease into it. And I am not going to take too long introducing esteemed panelists to introduce themselves over here. Take it away, Doc.
I was earlier here, so some of you have heard my background. I'm a psychiatrist in practice for 25 years, and I'm also founder and president at Headlight Health, where we are trying to improve access for mental health care to individuals in all the communities we serve.
My name is Chaitanya Pabbati. I'm also a psychiatrist, also at Headlight Health, following in the footsteps of Dr. Sheth and his partner, Dr. Inamdar, as we try to reshape the landscape of mental health.
I'm Venu Prabaker. I wear multiple hats. I'm an internal medicine physician. I've been a teacher for 35 years. I was assistant professor at Stanford for 7 years. I've been teaching medical students, residents, PA students from UCSD, USC, University of Nebraska, Yale University, 18 different universities. Founder of the several companies, and one of the companies I co-founded was bought by Humana. And now I'm retired. 2 years I retired, but I want to give it back to the community. So I'm in 5 charitable boards, and I'm also heading the advisory board for 6 startup companies.
Thank you so much. With this esteemed panelists over here, what we're looking for is unique insight, knowledge, science, and above all, heart into it. We've talked a lot about the science, we've talked a lot about technology, but at the basics of the core of it is the nuts and bolts. And what are those nuts and bolts? The internal mechanism, as I like to call it, or the inner engineering. And with that, I'm going to get into the first question over here. Before that, let me say something. As a life coach, I see people come here. And there's one thing that everyone is very proud to wear is burnout, as if it's a badge of honor. Let's be real, it's not. It just is not. It's shameful. We need to be embarrassed about that instead of mental health and illness. And resilience, at the same breath. It's not about pushing through. It's about moving forward. So with that, in today's conversation about building resilience in a post-pandemic world, let's collectively redefine what really wellness means to us, not just as individuals, but in our workplace as well. And when I say that, we mean let's connect, sometimes by disconnecting. And with that, my first question to you, Dr. Venu Prabaker, would be, we saw this surge during COVID, mental illness surge, and the post-COVID periods. What did you see? What was your observation?
Yeah, it was indeed. There are several reasons why this happened. They had cognitive dysfunction. We call that brain fog and memory loss and even persistent depression. So what has happened is the virus, COVID virus, penetrated into the brain, causes neuroinflammation. How do we know? We know by estimating the cytokinins in the blood. Okay, they are IL-6 and TNF-alpha. These are the cytokinins, surged tremendously. This virus also broke the blood-brain barrier. As you know, the brain is on purpose kept it in the skull so that nothing can penetrate. Okay, the heart is inside the rib cage only. The bowels are only in the abdomen, but the brain, which is like a cottage cheese, is kept in the skull. Not only that, God made something called blood-brain barrier, which will not allow anything to go inside. But these viruses went in there and occupied that, and it primarily affected amygdala, a part of the brain called amygdala, and it is a center for fear, depression, and emotion. Naturally, that will be affected. It also can affect the prefrontal cortex, so executive function is completely damaged. The stress around that area caused cortisol surge, which was persistent. And cortisol surge can cause mood disorders and cognitive impairment. And that also caused a condition called hedonia. It's called inability to feel the pleasure. So everything is because of all these catastrophe that happens in the brain.
Can we just chime in over here with that? That's about the brain. What do you see as a psychiatrist? What has it done? What has it translated in terms of us as human beings?
The pandemic was more than just a virus that infiltrated all parts of our body, our brain, our lungs, everything. It also changed the world that we live in. Many of us in healthcare now have adopted telehealth. In fact, it's hard to find a practice outside of surgical practices that don't rely on telehealth for a significant aspect of their clinical services. And even outside of medicine, I mean, all fields have incorporated telework. And while that's great, I mean, in medicine, the argument has always been, look, when you have the opportunity to connect with somebody virtually, you're breaking down barriers in terms of access to care. I myself have patients 50, 100, 200, 500 miles away from our office. And were it not for the virtual world, they wouldn't be able to seek care with me. And for many of them, there's no other option for care. But there's a cost to pay for this opportunity, and that is that isolation. The whole of 2020, before the first round of vaccines came out, most people didn't leave their homes for anything other than grocery stores. Obviously, regional exceptions to that, but for the most part, we were divided. And if you think back on the scope of human history, that never existed. Let's not even worry about the scope of human history. Let's just look at the last 25 years. Is carrying something on them, maybe more than one something, that didn't exist 25 years ago. Something with more computing power than the Apollo space missions. That is a monumental change in the fabric of society over 25 years. And it has fundamentally changed the way we interact with each other, interact with our communities, our homes, even with ourselves. And so much has changed in the world outside of our bodies. But almost nothing has changed over 25 years, 250 years, 2,500 years within our bodies. Like, the basic biology that makes us who we are hasn't really adapted very much. Minor things, but nothing on the scale of a cell phone or the internet or transcontinental flights. Like, those are unfathomable advances compared to what's happened internally. And so when you have a world that fundamentally shifts in such a catastrophic way overnight, to say nothing of the last 50, 100, 500 years of human existence, how can there not be turmoil? Not just in the brain, but in the more abstract idea of the mind. What is the impact of going from seeing people every day, shaking their hands, sitting next to them in an office, sharing a meal with them, riding public transportation home or to work or to school, till you rip all that out of a person's life? You take it away from a community. You fundamentally change, in some cases, destroy the very fabric of that community. And then we're surprised that people struggle? We shouldn't be. None of us should be. It was the most predictable outcome of everything that happened in 2020. And what we're left with now is not the effects, biological effects of a virus. What we're left with is the sociological effects of a different way of life. And that's where mental health and all of health has to really consider. You're not just treating someone who went to school, settled down, and is now in like a 9-to-5 work grind. It's that person in a community, in an environment that they were never equipped for. They were never trained to be there. But that's where all of us are. And when we think about resilience and when we think about preventing burnout, we have to model whatever we decide to do for the world that we're currently in. Not what existed 5 years ago, 10 years ago, 50 years ago, or 500 years ago, but the world we're in today. And part of that starts with acknowledging the difference between what our bodies were biologically designed for, where we were supposed to live, where we were thinking we'd live, and where we actually are living. Not just physically, but also mentally, spiritually, philosophically.
Real baseline in psychiatry and mental health is we look at everything in the construct of biopsychosocial model. Biological, that Dr. Venu Prabaker explained about what happened with, in that situation. I could be depressed without having COVID infection, and my biological reason would be different than if I were depressed first time after having COVID infection. So there is a biological part, psychological part, how I personally, individually handle that change in environment, the separation, worrying about my parents, worrying about my job, neighbor, finance, whatnot. And then the social part of it that Dr. Pabbati was alluding to. It created clearly social isolation. Earlier, I mentioned that social isolation is number one predictor of poor healthcare outcomes, poor economic outcomes, and early morbidity. So all those things happened in a span of days during COVID. So it's interesting that now we look at mental health in terms of that's a threshold and say pre-COVID and post-COVID. Our bodies are the same, as we all know. Some data are showing that there are some long-term effect or long COVID effect. We haven't defined them very well yet, but we are learning about that. But I think the thing that changed is our lifestyles and our mindset changed with COVID. So burnout before COVID were I'm having trouble in my relationship or at my work, or my colleague picks on me, or doesn't include me in the meetings, or steals my ideas, or this and that. During and post-COVID, the burnout liabilities changed. Many of the things that came up were we are noticing, psychological researchers are already publishing this kind of data, is that there is a bigger and wider ideological difference and ideological widening. We find people who are on the opposite spectrums more so than in the middle of the spectrum. And part of the reason is when there are two people with different ideas, opposing ideas, if you throw them together in the break room at work, or you have to sit in the same meeting across each other, you will find ways to find a common interest or something common. But when you are working remotely, when you are not around each other, now your ideological differences are only going to widen. And certainly social media and some of the other channels, they kind of flamed this sort of separation. So that is what we are seeing more now, which is different than pre-COVID, as to how the burnout related to lack of ability to engage ideologically with folks who have different way of thinking, countries, political parties, financial ideas, technological ideas. And in fact, at one place everyone is agreeing is AI, I should say that. But besides that, difference of opinion. So, and we are addressing that on our practice level, but I just kind of wanted to point it out what is different now.
Thank you so much. That was very insightful. And I have to agree with the biological, social, and the physiological aspect, the psychological aspect. And yes, that has actually had a huge shift. I'm saying that at a very personal level myself. And I can see that and relate with that. Now that makes all sense. If we were to diagnose this global mental health surge right now through two lenses, clinical and a psychiatric lens. This is a two-part question. What would you identify as the core dysfunction, and how can psychiatry balance medication, therapy, and community-based response to this approach?
Talk about the role of the primary care physician. So primary care physicians encounter 100 different things, including mental illness. But a lot of times they miss the diagnosis. So the patients may come with fatigue. The patients may come with memory loss. You need to find out what is happening. You have the records. The patient has had severe COVID, was hospitalized in the past. Immediately we need to seek the help of our mental health colleagues. There are some screening tools. We have annual health assessment. In that, we encourage, I always tell my PCP colleagues to use PHQ-9. It's a patient healthcare questionnaire, and GAD-7 questionnaire, which will elicit, even though the patient does not express themselves that they are depressed, they are anxious, these questionnaire will clearly tell us exactly what it is. If the primary care physicians are competent, they can start the treatment and observe. If not, then we need to get the help of mental health psychiatrist. One of the things I really like is collaborative care model. Okay, behavioral specialists, psychologists, psychiatrists, and primary care physicians, we all form an extended network and we all communicate with each other. And the moment we find a patient who is depressed and it's not real fatigue because all the other tests are completely normal, the patient does not have low sodium or diabetes or other illnesses which can cause fatigue or hypothyroidism, then we know that the patient is depressed or anxious. So we need to seek the help of the psychiatrist. So it's a teamwork. We all can work together as a team.
To build on what Dr. Prabaker is saying, there's no greater ally for anybody in mental health than primary care. Most people have a primary care clinician in their lives, but they don't have a mental health specialist. And so for them to get connected to mental health, the gateway is through the office of the primary care team. When we talk about like a global shift in mental health, a big part of this is people now being okay talking about needing to and wanting to access mental health services. So, I mean, the question that we always have to ask ourselves is it true that there's a definitive rise in the need for mental health services, or is it simply that we are finally acknowledging this thing that has always existed for decades and decades, but everyone was too afraid to talk about it? As with most things, I mean, the truth is somewhere, some combination of those two statements. But the greatest thing that we should all be excited about and glad for is that we are willing to talk about it. Not just psychiatrists, not just therapists, not just coaches, but just the general public. Like when mental health becomes part of the water cooler conversation, to go back to pre-pandemic terms, like that's how people talk about it. Like to Dr. Sheth, your point, like when two people with different ideological beliefs speak to each other over the internet, there's not a lot of incentive to collaborate. You can scream whatever you want, but when you're sitting across from someone at the lunch table, you're going to pull your punches a little bit, maybe try to listen a little bit more, hopefully learn something. That's how we have the privilege to be where we are today, where we can talk about the mental health needs, where we can talk about the rise in mental health services and the importance of integrating mental health into primary care in terms of something like the collaborative care model. You can't have mental health in a silo. It's always been kind of carved out, black sheep of medicine, whatever kind of terms we want to use that have been thrown out there. But if you want to address mental health needs and the impact of mental health on like neck down health, you have to integrate it. It can't be something that's stuck in a corner. No one really wants to talk about it. Dirty little secret. We're moving past that. And I hope one day I can say we've moved past that.
Building upon that, mental health, as Dr. Pabbati mentioned, has somewhat been on the dark space, kind of shaded space, somewhat on the gray space. What has happened is we have collectively, at the societal level, at the clinical level, at the healthcare system level, we have always looked at mental health as individual care. Most of the systems have not looked at it in a systematic way where they are talking about the scale or population health for mental health. It is always about this one person needs to go see a psychiatrist, this one person needs to go to the hospital, this one person needs to go to a coach or an IOP, or they need to go to detox program and whatnot. That conversation has shifted since COVID, because now we are talking about population health with mental health. When we saw that, again, statistics, some numbers here. Right now, we believe estimates from the studies, government studies, is that NIH studies, NIMH studies, that 1 in 4 people need mental health services, and about half of them actually attempt or get any service. There is just not enough access for mental health services. If we kind of extend that, what we have done differently and what we have learned from our experience in our company is that we looked for clients. We created access doors, like, big room, we are sitting inside, let's open all the doors. So we opened Facebook, we opened Google My Business, we opened SEOs, we opened social media, we opened referrals. What we found that when we got patients coming in from all these channels, the conversion rates were under 30%. So even if we get a lead and we try to bring them in, like we are bringing them in less than 5 days, we're looking for barely 30% that we could convert them into first appointment client. When we got referral from a primary care, a cardiology, OBGYN, or any other medical providers, and we followed up, our conversion rates were 95%. So we have data now with thousands of patients, thousands of referrals. It's a waste of time if you are going out to try to find one person at a time on Facebook or other kinds of channels. Nothing wrong with the portal. It's how we build trust for the coming in a referred patient or referred client. Because when they are referred by their primary care, their cardiology, OBGYN, pain doctors, or other providers, there is a built-in trust that my doctor must be thinking about me. That's why they are referring me to Headlight or they are referring me to mental health. So that is a 95% conversion, and we want to build upon that. We have exclusive partnerships with very large healthcare systems in the community, and we are building more of those. But I think that's what the data is telling us, and we are investing in the data, assimilation of data, creating all the action items out of the data.
One of the things as a primary care physicians we encounter constantly is denial. So whenever we talk to the patient as you have depression, immediately they turn around and make sure that nobody listens to that. Okay, they don't want to tell it to their life partner. Okay, they feel that it is something bad. As physicians, we cannot just say you have, depression. I wanted to write the medicine. You take the medicines and walk out. You need to have enormous communication. You need to talk to the patient, communicate with them. So if I say that you have high blood pressure, will you be offended? They'll say no. If I say that you have diabetes, no. Then this is also one of the similar conditions. That's about it. Okay, it is not your fault that you have high blood pressure. It is not your fault that you have diabetes. Same way, it is not your fault to have depression. The second thing they do is when you write a prescription, they tend to stop. Highest number of patients stop the medicines in psychiatry. Okay, so one of the things we need to tell them is it takes some time for the medicines to start working. So you need to take it for at least about a month or 6 weeks, 8 weeks before you see the difference. You just take it until then you'll tell me whether it's working or not. So we need to bring the patients back. And the best thing is psychiatrists are so beautiful in communicating skills. They have the knack because this is what they do all day long, communicating, talking to the patient, convincing the patient and everything. So they'll be able to connect with the patient. So that's one of the reasons why all the tough patients, because we have short of psychiatrists. Psychiatrists also shortage there. So it's very difficult. So we need to refer them only some of the difficult patients, and they easily convert them and make them take the medicines.
What I just heard right now, one thing that stood for me was conversation has shifted. I agree, conversation has shifted. But has the stigma shifted? Is the stigma shifting? Even just allow that to sit in for a minute and think about it. Of all the things that we've heard, we've imprinted, and the way we see mental health, depression, anxiety, and what it gets in us, we can feel it. So that stigma, has that shifted? And if that has, in your experience, or hasn't, at least what I see, what makes treating these post-pandemic patients, with burnout and anxiety, how challenging can that be?
Correctly use two terms here, shifted or shifting. Clearly it is shifting. It hasn't shifted completely. I think this is a place where there are different thoughts around it. But I would say what COVID did is it impacted everyone. It did not leave some people or some segments of people protected. Everyone was impacted with some level of mental health difficulties at the time. Some had more tools to address it. Some did not have enough tools. We heard about 94-year-old who first time got into depression because she could not see her grandkids and rest of the family for months at a time, sort of thing. Now, positive side of it. Social media and the inclusion of celebrities in talking about their mental health situations that improved the education, advocacy, participation. Look, this is a tech conference, and we are sitting here and talking about it. Like, I don't know, 10 years ago we would have done this. Or pre-COVID, we absolutely would not have done this pre-COVID. So, yes, it has been shifting, and it will continue to shift. And that's where I think that the more tech gets involved in it, so we don't look at it as a one-off problem, one-off challenge, one-off disease condition, one-off treatment. It becomes a global, a more cohort-based treatments, more population-based treatment. That will increase more adaptability.
It's shifting in interesting ways where you have people who fortunately are finally willing to talk about the things that they've been struggling with or others in their orbit have struggled with. You've also got a cohort of people who are being like exposed to this information for the first time, where it's like, I had no idea that these things can exist in my world and that there are people in my world who struggle with this. Like, how do you reconcile that fact? Like, this depression or anxiety or ADHD or bipolar disorder or schizophrenia has been a thing for so long, and now I can no longer live in ignorance of the fact that this exists, possibly in my own home, possibly in my own family, possibly within myself. That level of realization, and I think optimistically it spurs introspection and self-reflection and a desire for growth within a person. Like, that's been lovely. As a clinician, when you have patients who are educated, driven to learn, driven to understand themselves and the communities they live in, like, that's the dream. I'm sure it's similar for you as well. Additionally, what we see, I mean, you said the plus side of social media. I'll go to the other side of social media is there's no regulation. There's no quality control. Like in a previous panel, we talked about, hospital accreditation and licensure and like HIPAA rules and patient health information protections and all those things. Social media, the internet's the Wild West in the truest sense. A big part of the job now is saying, like, I'm so glad you went out and got all this information. I'm going to spend the next 30 minutes of our appointment debunking half of it. That's a delicate conversation to have at the best of times, and you really cross your fingers and toes that it all goes well, and there is a second appointment, or in our case, a fourth appointment to show, that the practice is built on sound fundamentals. But that's where the progress is made, right? Like, for when everybody knows, like, well, that must be the case. Well, chances are it's not. Just like depression is just for those people who are weak or whose parents didn't hug them enough or whatever it is. It's like, no. We spent decades disproving and changing the thinking. Now's the next challenge. It's like, well, what does that actually mean? Like, what are the actual risks and benefits of this medication versus that intervention? How do you tease apart the quality of the data that everyone has access to now? Like, that's the new role of clinicians, physicians, and especially in psychiatry. Like, dispelling myths, modifying what people truly hold to be true. That's how the new forward progress is being made.
As a primary care physician, they come with a laundry list of items, including headache and itching and rash and toe pain. Along with that, they also have anxiety and depression. And majority of the time, even if they come with depression, when I say that depression is severe enough, we need to start you on medicine, anxiety pursues immediately. Anxiety about taking the medicines. So the lot of times I will refer the patient to psychiatrist, so that when they go to a psychiatrist, they cannot talk about the toe pain and rash and all those things. They can talk only about the depression and anxiety. So I'm out of the way, so they can handle this and I can take care of the other issues.
I can see the yellow light already buzzing, and I'm getting anxiety there, Doc. What do I do? I could go on and on and on, but I'm going to be mindful of time. But there's this question that I definitely want to ask all of you before we end it. How has teletherapy increased access for rural marginalized population? And what are the gaps that you do see?
Clearly, telehealth has improved access. More providers are available that they could not before. More clients are able to seek care. It isn't just limited to rural, certain population types. Majority of the care is received by urban population. In fact, I-5 right now, there is a reason why you need to be on telehealth. or most of the day. People have even counted the loss of time from work if they had to drive to the office. Like if this is a 1 hour appointment and their drive is 40 minutes each way, now they have to miss 3 hours of work versus 1 hour of work. There are economic reasons. Gas prices in California definitely makes sense. So it serves all populations, and we see that there are maybe some changes coming by certain payers. So we'll have to watch for it. But the gaps that still remain, we feel, is certain population. Like it is very difficult to treat child, adolescent, younger age group on telehealth. There was already a gap in that field, and more providers are moving to adult patient care. So that gap is widening, and number of patients, younger patients who are reporting depression, anxiety has tripled almost in the last 5 years. So I think that gap, we need to address it at a crisis level to see what can be done.
Sometimes with the virtual world is people who don't have greatest access to internet, high-speed internet, whether the video loads. And then furthermore, with the best intention, it is really hard to forge a deep, trusting relationship across a 4-inch computer window, whatever it is. And let's be honest, a lot of people use their phones in their parking lots of their job. It's hard to develop trust. It's hard to develop that relationship. And then even if you're able to do all of that, especially in mental health, sometimes one of the most valuable things we can offer is a truly safe space. Like if someone is in an unhealthy relationship or in an unhealthy living environment, asking them to talk about that unhealthy, unsafe environment while they're in that said environment, it doesn't go very well. So there's always going to be a need, like a moral and ethical need for in-person care. And so where telehealth can really be of value is the cases where that isn't the case. Like, let's not create any additional barriers. Let's not make it harder to access something that's already challenging. Let's break down that barrier. Let's make it easy, whether you live in the city, where you live in the country, whether you have to drive on I-5 or not. Let's not waste more time than necessary to get that access to the care. And then for those individuals who really do need to be in person, that time is truly preserved and protected for them.
Patients with depression and anxiety seeing a psychiatrist, they need to have some therapy, several sessions they need to undergo. And it is prudent and time efficient and therapy efficient to have interaction through the telemedicine. As opposed to primary care, if the patient has heart failure, we need to listen to the lungs to make sure that the lungs fluids are getting better. When the patient is coming with a high blood pressure, we need to check the blood pressure in person to see whether the medicine is working or not. So there are a lot of differences to that. Primary care, whatever we do, we need to see the patients in person, examine the patient, whereas the psychiatrist can do the magic over the telemedicine.
I am getting anxious. I don't want to get depressed anymore. So I am getting anxious there. And all I'd like to say is, for me, the way I see it is, burnout to me is disconnection. And resilience to me begins in awareness. Awareness of yourself, physiologically, psychologically, mentally, and emotionally. Everything is connected. Anything is misaligned, you are misaligned in life. Thank you here, my esteemed panelists over here, for being today, giving so much of wisdom, and for an engaging conversation and having more conversations about mental health, why it's important, and how it has to be integrated into our healthcare system. We need to see that eyes wide open now. If not now, then when? And with that, I'd like to say thanks to the TAL team to organize this and to bring this at the forefront. Thank you so much.